Good evening. I want to welcome everybody to this week's session of Dermpath Unknowns Happy Hour. Before we begin, I want to remind you guys that we're going to be doing another board review for those of you who will be preparing for the Dermpath core exam and the applied exam. And if you haven't opened your email from Sagis at this time, you can go on to the sagisdx.com/education website and go ahead and register for that meeting. And we're very pleased today to have hosting this session our very own Dr. Maloney. Dr. Maloney is board certified in dermatology and dermatopathology. Did her medical school training at Yale and subsequently did a combination dermatology internal medicine residency at the Mass General, and then completed Dermpath fellowship at MD Anderson. And she spends time both doing clinical dermatology and dermatopathology. And Dr. Maloney is going to be discussing alopecia for us today. And so we're very happy to have you on board, Kuda, and looking forward to the presentation. If you have any questions at all, you can go ahead and post them to the education at sagisdx.com, and we'll be sure to get back to you. So without any further hesitation, I'll turn it over to you, Kuda. Thank you.
Thank you. So yes, I'm Kuda Maloney, and I'm really quite excited to be sharing with you some insights on alopecia. And so I think that for any good discussion about alopecia, we really want to feel comfortable with what normal scalp looks like first. So right here, we have a specimen from the scalp of a 31-year-old male. And what you appreciate, even just at low power, is the following. So the scalp typically has this rugation, this rugated epidermis, and we know that. We know that the scalp has this textured feeling compared to other areas of skin. And what's striking, of course, is that the scalp is chock-a-block full of these pilosebaceous units. In the upper to mid-dermis, we see these thick, full, sebaceous glands that are attached to these large, thick caliber hairs that have their bulbal base nicely situated in the fat. So these are normal terminal hairs. And we see some background minor perifollicular inflammation, but this is not significant. This is essentially background noise. I've mentioned a few structures, but I want to just go into a little bit more detail about and to understand what level of the scalp of the skin rather you're expecting to see each of these structures, because that's going to really inform us as we're looking at pathology and understanding what we're seeing and why. So what else do we see at each level? So here at the where we have our bulb, as I mentioned, there's going to be a background of fat, of subcutaneous tissue. Can you imagine if we're doing a cross-section or a horizontal section through the skin? You would see your bulb in cross-section, but you'd also see fat in the background, subcutaneous tissue in the background, so keep that in mind. If you're in the suprabulbar zone, you're going to see, again, your hair follicle in cross-section. You're still going to see some fat, but now we're going to start seeing some eccrine glands, right, in the suprabulbar zone. As we get up here again into the isthmic zone, we're going to see our bulb, our follicle, but in the background, there's going to be sebaceous glands, and we're going to have those pilar erector muscles. And then finally, in cross-section, when we're at the infundibular zone, we'll see our epidermis. We'll see our epidermis in the background. And so again, it's useful to just really understand the structure of the skin, and specifically for this topic in the scalp. The features that we're going to be discussing, I'm going to be showing them to you with some examples in vertical sections. So basically top down, just as we're seeing the skin here, and some of them in horizontal section. And I'll explain in each case, what the pertinent features are that you can see in each scenario. What I like about the vertical section is that you are seeing everything in one field, right? You can see the epidermis, dermis, and subcute, so you can get an idea of the overall pattern of things. Now, where the vertical section can fall short, though, when you're looking at hair loss and alopecia, is that it only samples or only shows you a sampling of the hair follicles. When you're looking at things in cross section, you basically see all the follicles that are represented at that level in your biopsy. And so of course, it's giving you quite a wealth of information. And then just to finish up on this introductory slide, we like to standardize things, right? It helps to compare one case to another. And so the general standard for looking at hair is going to be to take a 4mm punch biopsy. So whether you're looking at it in vertical section or horizontal section, we like to get those 4mm punches. And so again, as I'm pointing out features here, we're really making a point about what we're seeing to inform our dermatologists. What features can help them to identify treatment points that are ultimately going to help the patient? What tools can they select in this often difficult to treat category of conditions? The alopecias, we generally speak about scarring versus non-scarring, so that's the primary breakpoint. But again, there are some specific features that can help us delineate things a little bit more. Okay, so let's just jump into it here. All right, so with this case, now I want you to just keep in mind how our normal scalp looked, because it's strikingly different, right? So we have our rugated epidermis, but what we see immediately at low power is just the absence of hair. Okay, and as we're taking a closer look here, we have a nice good terminal hair here. It's situated in the fat, right? The bulb is situated in the fat. But we see that other hairs that are present are not. So fewer hairs, we got some loss of hairs. The hairs that are present are actually, for the larger part, not situated in the fat. And then most important, and where the hair essentially has traveled upwards out of the normal position, there's a trail that's been left behind in the wake. Okay, so that's called a fibrous strema or follicular strema or stele. So what's causing this? That's the question. Why is this happening? Well, look at this. So we have another scenario here where there's clearly an absence of hair. There was a hair there before, but it's gone, it's lost. We have our nice stele there, but look at this. We see this distorted hair follicle, and within it, there's an atypical pigmentation. So this is a melanin cast. We have another one here. So these are hair follicles that have these pigment or melanin casts, which is very typical of a traumatic process such as traction alopecia or trichotillomania, and that's the diagnosis here. One comment I'd like to make, so in this section, for example, we are seeing the same thing. We have our hair loss. This is another case. This is the same case of traction alopecia. We have some sebaceous glands. They're not gone. Okay, so that's important to note for our differential diagnosis. And then as far as inflammation is concerned, we really just have the same kind of background noise level of inflammation that we saw when we were looking at our normal skin. So traction alopecia, we have hair loss, we have some of those pigment casts. Because the hair has been traumatized, it's kind of been shocked by this traumatic process. There's a change or an alteration in the follicle. Okay, so that's going to be that shift from those nice open anagen follicles to the catagen telogen. So we're seeing that, right? We're seeing that that follicular distortion and change. Okay, we have a catagen telogen shift, and this, the majority of the hairs that we are seeing have experienced that. There is some miniaturization, but again, the catagen telogen shift, the absence of the hairs and the pigment casts are the overwhelming features in this example of traction alopecia. Contrast that to this example here. So on the scalp, what's really striking here is that we have our some nice terminal hairs again. Okay, so quite 1, 2, 3, 4, 5 thick caliber, large hairs that are situated, the base or bulb is situated in the fat, but the majority of the hair bulbs and the hairs are actually situated above the fat. Okay, so we're in the lower dermis and mid dermis for the most part, as far as our bulbs are concerned. And this is not what we expect, right? So this is pathologic. And we want to understand why that's happened. So let's look around and understand what other features there are present here in contrast to our last case. So we have this miniaturization, that's what I've just described, where we have more hairs that the base or bulb is situated in the dermis rather than in the subcute, and it is profound, it's striking. We also have some of that catagen telogen shift. So we have some hairs where we just don't have those nice open anagen follicles at all, right? But other than that, we don't see those pigment casts, okay? We see sebaceous glands that are nice and preserved, so they are still there. And again, this is a differential diagnosis point. We see some of that inflammation that really looks about the same amount as we had with our background level of inflammation that we talked about as just background noise, typical of the scalp. So this is an example of androgenetic alopecia. And again, what's really striking is just the level of miniaturization compared to the little bit that we saw with the traction alopecia, where the most striking finding was really that catagen telogen shift. And then we were lucky enough to see those pigment casts with some distorted hair shaft remnants. Okay, so keep these two in mind. This is another example of androgenetic alopecia. So I'll put that out there up front. Same diagnosis, androgenetic alopecia. But what's important here, now we've switched over from looking at a vertical section to seeing a horizontal or transverse section. And remember, we talked about the fact that one of the important things we want to understand when we're looking at horizontal transverse sections is what level of the epidermis we're looking at, what level of the skin we're looking at. So how do we know that? Well, let's take a look. So we'll look at the follicles in a minute, but let's first look at the background. So we have some subcutaneous fat and we have some eccrine glands. Yeah, we're starting to see we see a bit of sebaceous glands, but mostly we have the subcutaneous fat and the eccrine glands. That's most prominent. So we must be at the supravalvar zone. Okay, Now, when we're in the suprabulbar zone, bulbar or suprabulbar, what do we expect to see in terms of follicles? Well, we expect to see terminal hairs. We expect to see large caliber hairs, large follicles that are all essentially the same size, and their bulbs are just situated there in the fan. Well, we don't quite see that. Clearly, first of all, we do see absence of hair, so hair loss. And of course, there are metrics, there are counting protocols and so on. But we're just doing an overview to just get a sense of how we look at alopecia. So just taking a global look, we can see that there's just areas of absent hair. We can see that there used to be hair there, but there's an absence of it now. Here too, there's just areas where there's just no hair follicle. And it's been replaced by something else, this loose connective tissue. And those are, again, our fibrous streamers, our stellae, but now we're seeing them in cross-section. And then additionally, as far as the follicles themselves are concerned, they just don't look like each other that much. You know, this one does not look like this one, which does not look like this one, which does not look like this one. So there's variation in our follicles. And in the normal condition, we're not going to see that in this location. In the suprabulbar and bulbar zone, all our follicles should look essentially like each other, same size, same shapes, so on. They should look similar. So why is that the case? Why are we seeing this kind of variation? Well, what that means is we're seeing the follicles at different levels, which means therefore that there's been some sort of movement upwards of our hair follicle. Essentially, we have had miniaturization. So the point here is that the best place to look for miniaturization is in the bulbar, but particularly the suprabulbar zone. That's where you're going to really identify this variation in the size of the follicles, and that's abnormal. If we try and look for miniaturization when we're up, for example, in the infundibulum or isthmic zone, well, you know what, we are probably going to see some variation, but that's not unexpected, because remember, the scalp does actually have, even the scalp does have some portion of hairs that are going to be vellus hairs. And so those hairs are going to be smaller caliber, smaller hairs, etc. And so there's going to be some portion of that anyway. But in the bulbar and suprabulbar zone, that shouldn't be happening. We should not have these small hairs. So this is clearly miniaturization. And again, miniaturization is a salient feature of androgenetic alopecia. Okay, so we got our miniaturization, we got our fibrous streamers. They know that's a sequela of that miniaturization process, but we don't have concentric thick scars, so we're non-scarring, in a non-scarring alopecia. We do have some catagen-telogen shift. So we have quite a few of our hairs that are represented have gone into the catagen-telogen phase. And there are numbers to all this. So, when you're looking to see if there's miniaturization, your terminal to vellus hair ratio should be, is going to shift. Terminal to vellus hair ratio should be 2 to 1 or greater, meaning that there should be more terminal hairs at this level. Okay, but we have almost kind of almost like a 50-50 here. And then as far as catagen-telogen percentage is concerned, you have a catagen-telogen shift when you have greater than 15 to 20% of your hairs have now gone into the catagen-telogen phase. All right, so two last points about the androgenetic alopecias. So I mentioned the fibrous streamers, and there are stains you can do. There is Elastin Van Gieson stain that can just show you that travel that tract that the follicle makes as it moves up into the higher levels of the skin with miniaturization. And of course, androgenetic alopecia is in the non-scarring category, but with end stage or chronic androgenetic alopecia, you can certainly have or form a scar. And then in general, one last point about the androgenetic alopecias, at the level that we're looking here, we're not really going to appreciate much about the sebaceous glands. But early on in androgenetic alopecia in general, your sebaceous glands are going to be preserved. So this was the first example that I showed you. We have nice preservation of our sebaceous glands. Later on, with an end stage androgenetic alopecia, you can certainly have some atrophy of those sebaceous glands. Contrast to this condition. So again, we're looking in transverse section, okay, a horizontal section, and always we want to first of all decide what level of the skin we are looking at. We don't have a lot of help in this example, but we have some. We just have to find it. Okay, and we do see that we have our pilosebaceous glands there. There they are. So we have pilosebaceous glands. We know, therefore, that we must be in the isthmic zone, right? We're in the isthmus, but we don't have sebaceous glands, and that's really striking. I mean, these are gone. The sebaceous glands are absolutely atrophic. They are lost here. So let's keep note of that. That's a very important differential diagnostic finding. What else do we see? So we absolutely see that there's a good amount of inflammation here. This contrasts with the other examples that we've seen so far, where we really just didn't have much inflammation to speak of. But here we see that perifollicular inflammation and the inflammation surrounding the entire follicular units. And it looks like it's mostly lymphohistiocytic. And then we also see that there's a striking catagen telogen shift. So certainly in this example, more than 15%, 15 to 20% of our catagen telogen, of our follicles are in the catagen telogen phase. Okay. Now, when we see inflammation and this catagen telogen shift, we have to consider that it's just the inflammation itself that causes transition. So it's not specific, it's not quite a specific finding. When you see it with inflammation, it really just tells you that there's a robust enough inflammation that you're starting to get this kind of shift over. And then in terms of density, honestly, follicular density, it's mostly preserved. We have a few streamers, but not a whole lot. The follicular density is mostly preserved. But again, what's so striking is just being sheer loss and absence of an atrophy of the sebaceous glands at this level. So what can do that? Well, what's so useful about knowing that piece of information is that there is a condition, one condition in particular, where that can be a key finding, and that's actually psoriasis. So psoriatic alopecia, the sebaceous gland atrophy can really be a defining feature. And the reason it's really quite helpful to know that is because clearly at this isthmus level, you're not going to have your epidermis available to you to make that diagnosis of psoriasis. We're used to seeing that psoriasiform hyperplasia and the features that we associate with psoriasis. But if we don't have epidermis, how can we do that, right? So knowing that this kind of profound sebaceous atrophy can be a clue in that you're dealing with psoriasis is just really a good thing to know. And again, it's an inflammatory alopecia, so it's going to be on the differential diagnosis of some of the other more inflammatory also non-scarring, but inflammatory alopecias. So let's keep looking and see what else we have. And I'm just going to backtrack one slightly here. Okay. Now, let's look at this example. So this is vertical section again, and this is one of those cases where we're really actually quite glad to have the vertical section, because we can really take a top-down approach and see what's happening in the epidermis, dermis, and subcu to help lead us to our diagnosis. And what's quite striking from a pattern perspective is really just this lichenoid band-like infiltrate that we have with some have some level of interface happening in the background as well. A bit of plugging here, but what's notable is just this perifollicular, peri-infundibular inflammation. You see how we have this inflammation really that's quite concentric in the infundibular zone, and it really doesn't go further than that. We don't see that inflammation going into the subcutaneous fat at all. It's really localized to this peri-infundibular location. And so all those other factors, you know, we certainly want to keep them in mind. I'm seeing catagen, telogen shift. Yes, we are seeing some, but we have a robust inflammation, so that can certainly happen. You know, miniaturization, etc. But the main point is we have this pattern that is just absolutely diagnostic. So this is an example of Lichen planopilaris. Okay, so really, for all intents and purposes, histologically, essentially the same diagnosis. So this happens to be a case of frontal fibrosing alopecia. And, you know, we don't have that lichenoid infiltrate so much, but we do have some concentric fibrosis that is really very, very striking. So you see the hair follicle and you see that fibrosis that is very concentric. And so that's quite typical of FFP. We can certainly have some interface as well, but that fibrosis, you can just really appreciate that even at low power. Okay, and on the differential diagnosis of both of these, so in this case, what we really appreciate, always trying to discipline ourselves to take a look from top to bottom, but we really see that there is clearly some interface inflammation here. And we even appreciate that there may be some basement membrane thickening and even some follicular plugging, one of the examples. And then the inflammation, that perivascular, periadnexal inflammation that is superficial and deep, right? We really appreciate it throughout our specimen. So this is really just a great case of discoid lupus here, which certainly is often more represented in the scalp. And I want to just go back and make sure that we cover some of the other differential diagnoses in these inflammatory, in the inflammatory differential here. Okay, so here we go. All right, so another inflammatory process, and again, we're looking at a horizontal section. So we're going to do our usual process. We're going to figure out where we are, what level of the epidermis of the skin are we looking at. And we see those nice full sebaceous glands. Maybe there's a pilot erector muscle or two. So we know that we're at the level of the isthmus. So we've got that sorted out. And do we have globally just can we appreciate that there's some hair loss? And certainly there is, areas where we just see that there should be a follicular unit and there isn't. But what's so striking here are two things. First of all, this dense perifollicular inflammation. I mean, this is just really, really profound. It looks almost like the swarms around this follicle, which is causing some destruction. And when we take a closer look at the cells, so these are predominantly lymphocytes. Sometimes we can even have some pigment incontinence from the that robust inflammation. And then alongside that inflammation, we have that catagen-telogen shift. You can see that certainly greater than 15% of these follicles have undergone that transition, but again, it's associated with an intense inflammation, so that can certainly be the cause. Now, I want you to remember our example of psoriasis, because that is also an inflammatory process, right? And we had a good amount of inflammation in that example. But again, what was so striking was the absolute loss of those and atrophy of those sebaceous glands at the very same level. And we have this example here. This is alopecia areata. The sebaceous glands are just not lost in that way. They're quite nicely preserved, actually. So again, I just want you to keep that particular point in mind. Okay, so we've done a pretty good overview, I would say, of the both scarring, a few scarring, but mostly the non-scarring alopecias that are more common for us to see. So just to recap, we talked first about traction alopecia, traction and trichotillomania. Those are both going to be non-scarring. We also spoke about androgenetic alopecia, which for the most part is going to be non-scarring in its earlier and mid phases. We looked at psoriatic alopecia. We looked at alopecia areata. Telogen effluvium, the main feature again there is going to be that catagen-telogen shift, really without necessarily any real sense of a lot of hair or follicle unit decrease. It's just really that catagen-telogen shift. And then we started talking about some of the scarring alopecia. So we've looked so far at Lichen planopilaris and its family member, frontal fibrosing alopecia. We've looked at Discoid lupus. So let's keep going with those more scarring alopecias. All right, so this is a kind of a fun case to look at. So what we appreciate immediately is that we have, in particular, this central follicle or group of follicles, this pilosebaceous unit. And overlying it is this really, and surrounding it is this very dense kind of suppurative inflammation. And there is ulceration. We just don't have the epidermis maintained here, this kind of pustular zone which has caused some ulceration, overlying again this particular group of hair follicles. And what's so interesting about it is that this inflammation is really, really dense. But for some reason, it just cuts off once we get to the subcutaneous tissue. It doesn't go into the subcu. It's really just tracking along the length of the hair follicle that is infundibular and isthmic, right? It does not bother at all with that bulbar zone and into the suprabulbar zone. So that is a diagnostic feature. Additionally, we have to look at the cell type. When we see all this busyness, we want to know what are those cells, what are those inflammatory cells. And it's like ants teeming all over the place. There are just these neutrophils upon neutrophils upon neutrophils. Okay. Yes, there's some mixed inflammation, but the predominant cell type is these neutrophils. Stepping back a little bit again, we see that there's some polytrichia. So the hair follicles are essentially fusing. So you have 1, 2, 3 hair follicles all kind of fused together. And that's also a bit of a diagnostic, although not a completely unique feature. This is an example of folliculitis decalvans. And so remember, with folliculitis decalvans, you have this recurrent pustule formation, these separative pustules, and each flare essentially a scarring process takes place. You end up with essentially a scarring alopecia because of this recurrent, robust inflammation. And that polytrichia, where you have fusion of the hairs, is part of that scarring process. So let's contrast it with this other condition where we can certainly have a very robust inflammation as well. So we're seeing this zone of inflammation that extends from what would be the infundibular zone into the isthmus. But again, it doesn't all that much bother with the deep subq. It's very much dermis to upper dermis, so there's sometimes it can be deeper. And what's striking here is that you just seem to have this breakdown, this busting open of your hair follicles, right? These follicles are breaking open. And this destructive piece, this destructive component is appreciable too, in the fact that you have this red blood cell extravasation, you have bleeding essentially with this whole destructive process. And look at these free hairs, all these free hairs that the inflammation is surrounding. Okay, so I'm going to tell you that this is the same as this condition, same diagnosis. So we're seeing that same scenario where we have these free hairs, but we just don't have that robust inflammation quite as much. We have our follicles, in this case, with some sort of plugging going on, and there is certainly peri-follicular inflammation here, but we also have these more chronic zones where the inflammation isn't quite as profound, but instead of inflammation, we now have this kind of scar. We have this keloidal background, okay? And so both of those examples are acne, keloidalis, nuchae. And one thing I really should mention is that this cell type is going to be a little bit different. So we spoke about the fact that with folliculitis decalvans, when predominant cell type is those neutrophils that are involved in that pustular process. While here, when we take a look around, we have a good number of plasma cells, right? We have lymphocytes, but we also have a lot of plasma cells. And yes, we're on the scalp. We know that, on the head and neck, plasma cells can be overrepresented, but this actually is a noteworthy feature of acne, keloidalis, nuchae. And I think this example really just shows just the extent of plasma cell involvement. Look at those plasma cells, sheets and sheets of those plasma cells in addition to those lymphocytes. So just remember that too for acne, keloidalis, nuchae. And another feature that these two diagnoses share with each other, in addition to being very inflammatory in one phase, but leading ultimately to scarring as a result of that suppurative dense inflammation, is a polytrichia. And again, polytrichia is just another sequelae of scarring. It's just another consequence of these scarring processes. So let's look at a less inflamed diagnosis where we're also seeing polytrichia. Okay, so this is again a horizontal section. So we know what we have to do. We have to figure out what level of the skin we are at. And this one is another one of those tricky ones. We don't have a whole lot of help, but we do see that pilosebaceous unit. And so we know that we are at that isthmic level, but we just have a profound absence again of sebaceous glands. And let's take a look around and see what our other example has for us. We'll take a closer look at that in a second, but bottom line is we're at the isthmic level. And we clearly see that there is profound hair loss here. We see areas where we would expect to have hairs and we just don't have them. And what's also notable in this example is that we don't just have those loose connective tissue collections, we have actual dense scar here, right? This really kind of concentric fibrosis of a good scar. And then looking at the anatomy of the hair follicles, you know, we talked about it a little bit, but there's this polytrichia. So that's just, again, another feature of scarring. So we figured out that this is a scarring alopecia, but which one? And so let's look at that actual follicles, what's going on there. And we see these nice, and that's a nice open follicle with a normal structure. We see that inner root sheath that is as it should be. It's intact. While compared to this, for example, we have that inner root sheath and it's kind of fibrillar. It's breaking down essentially. That is desquamation of the inner root sheath. Okay, so that's an example of desquamation of the inner root sheath. Okay, well, we can accept that. You know, this is here, this is an example at the isthmus. So the inner root sheath starts to break down at the isthmus. So in this section, that is not diagnostic. Well, here, okay, so now we're a little bit lower. Here, we're in the subacute. And we're seeing, you know, it's a decent example, but we have a desquamation of the inner root sheath happening in this example as well, but this is not acceptable, right? We are in the subcutaneous fat. We don't expect to see inner root sheath desquamation at this level. So if we're at the subcutaneous fat, that means we're bulbar, right? So we have a bulb here, but that inner root sheath is breaking down. So that means that this is premature desquamation of the inner root sheath. And so that combination of features, premature desquamation of the inner root sheath in a background of a scarring alopecia, this is going to be CCCA, okay? Our centrifugal cicatricial alopecia. All right, so we have covered in this time really an introduction to how to look at and differentiate between the various non-scarring and scarring alopecias. And I think there are really some very good diagnostic points that help to differentiate between them. And this has been fun for me, and I hope this was fun for you.